Thank you, everyone. We are at 55 after the hour, and we will reconvene the ACIP meeting. First up, we have Dr. Ann House, who will speak about VSAFE and VAERS and what we know about third dose and simultaneous vaccination. So, Dr. House, the floor is yours.
Thank you. Can you hear me?
We can. Please go ahead.
Great. Next slide. COVID-19 vaccines are being administered under the most intensive vaccine safety monitoring effort in U.S. history. CDC is monitoring the safety of these vaccines through 4 complementary systems: VSAFE, VAERS, VSD, and CSA. There are also additional systems in place managed by government partners. Next slide. Today I'll focus on data from VAERS and VSAFE. Next slide. The Vaccine Adverse Event Reporting System, or VAERS, serves as an early warning system for vaccine safety. It is co-managed by CDC and FDA. Next slide. Anyone can submit a VAERS report regardless of the plausibility of the vaccine causing the event or the clinical seriousness of the event. The key strengths of VAERS include rapid detection of safety issues and detection of adverse events. Limitations of VAERS include that it's a passive surveillance system that relies on voluntary reports, has inconsistent quality and completeness of information, reporting biases, and, importantly, cannot determine causality of adverse events. Next slide. As of October 10, 2021, there were 4,990 reports to VAERS following dose 2 of Janssen or dose 3 of mRNA COVID-19 vaccines. The median age was 64 years, and 63% of reports were from women. Next slide. Race or ethnicity was unknown or incomplete for 49% of reports, and 39% were from persons who identified as white, non-Hispanic. Next slide. Overall, 94% of the 4,990 VAERS reports following dose 2 of Janssen or dose 3 of mRNA COVID-19 vaccination were non-serious. This varies slightly by vaccine manufacturer, but is similar to what we've observed for COVID-19 vaccines overall and other vaccines in general. Next slide. Among serious reports, the most common adverse event reporting to VAERS was extra dose administered. Among non-serious reports, the most common adverse event was interchange of vaccine product. This may mean that the additional dose was given in error or given outside of recommendations at the time. For federal law, serious reports include reports of hospitalization, prolongation of existing hospitalization, life-threatening condition, permanent disability, congenital deformity or birth defects, or death. Also, please note that these adverse events are not mutually exclusive, and a report may include more than one adverse event. Next slide. Among the millions of persons who have received a third dose of mRNA or second dose of Janssen COVID-19 vaccine, there were 30 reports of death to VAERS. There were no reports of death following dose 2 of Janssen. The median age was 79 years. Median time elapsed from third dose to death was 2 days. A CDC physician reviewed the available documentation, including death certificates, to determine a preliminary impression of cause of death. We were unable to determine cause of death for 8 reports due to insufficient data. Next slide. VAERS is also monitoring reports of adverse events following co-administration of COVID-19 vaccines and other vaccines. Most reports to VAERS did not specify the vaccine type administered with the COVID-19 vaccine. Influenza and zoster vaccines were among the most common vaccine types specified. The most commonly reported adverse events included extra dose or expired product, systemic symptoms, or adverse events unique to zoster. VAERS will continue to monitor adverse events following co-administration. Next slide. Now I will review data from VSAFE. VSAFE is a voluntary smartphone-based safety surveillance system. VSafe allows existing participants to report that you're receiving an additional dose of COVID-19 vaccine, and new participants to enter information about all doses of COVID-19 vaccines received and complete health surveys on their most recent dose. VSafe health surveys are sent during the week following each dose of vaccine and include questions about local injection sites and systemic reactions, and health impacts, including inability to perform normal daily activities, inability to work or attend school, and receipt of medical care. Additional health surveys are sent weekly through 6 weeks after vaccination and at 3, 6, and 12 months after vaccination. Next slide. The key strengths of VSafe are that it's easy and quick to use, includes active outreach to participants, and collects longitudinal data. The key limitations include that enrollment in VSafe is voluntary and requires a smartphone, and importantly, cannot determine causality of adverse events. Next slide. As of October 10, 2021, over 274,000 VSafe participants had reported an additional dose of COVID-19 vaccine. 62% of participants were female. 39% were aged 65 to 74 years. 90% of participants identified as non-Hispanic and 84% as white. Next slide. This table shows the patterns of vaccination for VSafe participants who reported an additional dose. The columns show primary series received, and the rows show additional dose. Bolded in blue are those who received the same manufacturer for primary series and additional dose. Over 98% of participants reported a third dose from the same manufacturer as their primary mRNA vaccine series. Most participants reported 3 doses of Pfizer-BioNTech vaccine. Next slide. This figure shows the top 10 solicited reactions reported at least once during days 0 to 7 after dose 3 of Moderna or Pfizer-BioNTech vaccine. Moderna is shown as blue and Pfizer-BioNTech in orange. Pain, fatigue, myalgia, and headache were among the most frequently reported solicited reactions for both vaccines. Next slide. This figure shows reactions and health impact events reported at least once during days 0 through 7 after Pfizer-BioNTech vaccine by dose. The odds of reporting an event following dose 2 and 3 were compared using a multivariable generalized estimating equations model that accounted for the correlation between participants and adjusted for demographic variables. P-values less than 0.05 were considered to be statistically significant and are indicated here by an asterisk. Injection site reactions, systemic reactions, and health impacts, including inability to perform daily activities and inability to work, were all less frequent following dose 3 than dose 2. Next slide. This figure shows reactions and health impact events reported at least once during days 0 through 7 after Moderna vaccination by dose. Injection site reactions were more frequently reported following dose 3 of Moderna vaccine than dose 2, while systemic reactions and health impacts, including inability to work, were less frequent following dose 3 than dose 2. While these differences were statistically significant, the magnitude was small. Next slide. VSafe is also monitoring reactions reported following co-administration of COVID-19 vaccine and other vaccines. Over 65,000 VSafe participants reported receiving another vaccine at the time of their COVID-19 vaccination. Most were 18 to 75 years. Nearly 90% of co-administered vaccine was given with dose 3 of COVID-19 vaccine. VSafe will continue to monitor reactions following co-administration. Next slide. These data are subject to a number of limitations. First, both VAERS and VSafe are voluntary systems and are likely not representative of the vaccinated U.S. population. Second, additional dose recommendations included immunocompromised persons who completed a primary series of mRNA COVID-19 vaccines. However, VSafe does not include specific information about immune status. Additional dose recipients likely included immunocompromised and non-immunocompromised persons, and immunocompromised persons might have different reactogenicity than immunocompetent persons. Third, approximately half of mRNA's third doses are among persons aged 65 years and older who may have different reactogenicity than persons in different age groups. Fourth, at this time, data are limited to determine patterns of adverse events after receipt of second dose of Janssen or from a manufacturer different from the primary series. This also limited our ability to identify rare adverse events. Finally, complete medical review of deaths following vaccination reported to VAERS is dependent on the availability of medical records, death certificates, and autopsy reports, which may be delayed or not available. Next slide. To summarize, we did not observe any unexpected patterns of adverse events. However, the data are limited at this point to identify rare adverse events. Nearly all reports to VAERS were non-serious. Most commonly reported were vaccination errors and systemic symptoms. Most VSAFE participants reported a primary mRNA vaccine series followed by dose 3 from the same manufacturer. For Pfizer-BioNTech, local and systemic reactions were reported less frequently following dose 3 than dose 2. For Moderna, local reactions were reported slightly more frequently and systemic reactions slightly less frequently following dose 3 than dose 2. Next slide. VAERS and VSAFE will continue to monitor safety of additional doses of COVID-19 vaccination. Additionally, Vaccine Safety Data Link will incorporate additional doses into its ongoing safety monitoring, and CISA will be available to consult on clinically complex adverse events. We will update ACIP as additional data become available. Next slide. Thank you to the many people who contributed to this data. This concludes my presentation.
Thank you, Dr. House. And given we have a series of 5 safety presentations, what I'll do is just take a moment to ask if there are any clarifying questions on this particular presentation, but we will open up discussion at the end once all of the presenters have completed their slide decks. Are there any clarifying questions people would like to ask? Okay, I see no hands raised yet, so why don't we move on to Dr. Tom Shimabukuro, who will be presenting a range of COVID-19 vaccine safety updates. Dr. Shimabukuro, the floor is yours.
Thank you, Dr. Lee. Next slide. Today I'll be presenting an overview of myocarditis following COVID-19 vaccination, really as a lead into some more specific presentations you'll be getting following my presentation, an update on the safety of Janssen COVID-19 vaccine, and then a brief analysis on the safety of Janssen COVID-19 primary vaccination, followed by an additional mRNA COVID-19 vaccination. Next slide. Next slide. Evidence from multiple safety monitoring systems in multiple countries supports the finding of an increased risk of myocarditis and myopericarditis following mRNA COVID-19 vaccination. The risk is highest in adolescents and young adults, higher in males compared to females, and higher following dose 2 compared to dose 1. Symptom onset clusters within a few days of vaccination, mostly within a week, and cases have tended to be clinically mild. Next slide. So in the next several slides, I'm going to be giving highlights from FDA monitoring, Department of Defense monitoring, Department of Veterans Affairs monitoring, just mentioning, briefly mentioning some international surveillance efforts, and then giving you an update on the CDC investigation of long-term effects of myocarditis. VAERS and VSD updates will be provided separately during this session. Next slide. So I'll first be providing some high-level updates from a presentation that Dr. Wong from FDA gave at VRPAC last week on surveillance of myocarditis and pericarditis and mRNA COVID-19 vaccination in the FDA's BEST system. Next slide. So BEST is FDA's Biologics Effectiveness and Safety Initiative, And within BEST, FDA has looked at myocarditis and pericarditis in the first 1 to 7 days following receipt of mRNA COVID-19 vaccines and looked at incidence rates and incidence rate ratios for Moderna versus Pfizer BioNTech COVID-19 vaccination. I'll mention that the full presentations are available. You can access them at the link at the bottom of the slide. Next slide. So just to summarize the key points from the incidence rate estimates, they are highest in males. This is for BEST, highest in males ages 18 to 25 years. More events were observed post-dose 2 than post-dose 1. And there was a wide range of incidence rates among the 4 BEST databases with wide confidence intervals that they used. And then the incidence rate ratios comparing Moderna versus Pfizer vaccines. The preliminary results in BEST from the FDA analysis do not support a significant difference for males 18 to 25 years between the 2 vaccines, although the estimates had large uncertainty. Next slide. So this slide was provided by our colleagues in the Department of Defense. The military health system continues to identify and follow patients with myocarditis following COVID-19 vaccination. The overall rate of myocarditis within 7 days of vaccination is 10 cases per million doses, but the risk is strongly dependent on patient age and sex and vaccine dose and type. The rate of myocarditis in younger, and under age 20 males after second dose is greater than 100 cases per million doses. Approximately 2/3 of patients report feeling fully recovered within 6 weeks of diagnosis. And the standard American College of Cardiology recommendations limit strenuous activity for 3 to 6 months. Follow-up within the military health system is ongoing. Next slide. The next couple slides have been provided by our colleagues in the Department of Veterans Affairs, and the VA conducts active surveillance rapid cycle analysis for COVID-19 vaccines. They use a weekly analysis comparing observed to expected numbers of pre-specified outcomes from historical rates adjusting for sequential tests. They also conduct near real-time chart reviews for assessment of specific incident events, and that includes an initial chart review to assess presumptive events, and then a more detailed chart review. Next slide. So on the top here is a description of the vaccinated population in the VA. There have been 3.5 million total Moderna doses administered, 3.1 million total Pfizer-BioNTech doses administered, and limited use of Janssen in the VA population, approximately 270,000 doses. Vaccinated population is 89% male, 60% age 65 years and older, with the Janssen vaccinated cohort a little bit younger than the mRNA vaccinated cohort. There have been no statistical signals for myocarditis or pericarditis with any of the COVID-19 vaccines, although limited data are available for Janssen. Of the 7 chart-confirmed myocarditis or myopericarditis cases in the VA surveillance, 6 were in males, 1 in a female. Median age was 37. Median onset was 3 days. Most have been after dose 2. The highest rate was observed in 18 to 39-year-olds, in all cases clinically resolved. Conclusions are that the absence of a myocarditis signal in the VA data are likely due to age differences in the VA population. Next slide. I want to mention that there is surveillance ongoing in other countries, in particular in Israel, which has used the Pfizer vaccine, but also in Canada and in Europe and elsewhere. The findings have been generally consistent with what we've observed in the United States. They've observed an increased risk of myocarditis with mRNA vaccination. And in some cases, such as in Canada and in some of these Nordic countries, a differential risk, with the risk being higher for Moderna compared to Pfizer. Next slide. So I want to give a brief update on the CDC enhanced surveillance for myocarditis outcomes after mRNA COVID-19 vaccination in various case reports. The purpose of this enhanced surveillance activity is to assess functional status and clinical outcomes among individual individuals reported to have developed myocarditis after COVID-19 vaccination that have met the case definition. It's a two-component survey conducted at least 90 days after the onset of myocarditis symptoms. It includes a patient survey followed by a healthcare provider survey. We began data collection in late August, and we anticipate it will continue at least through November. Next slide. As of August, VAERS had received 826 reports of myocarditis or myopericarditis after COVID-19 vaccination that met case definition. To date, around 680 patients have reached the 90-day post-myocarditis diagnosis window. Of these, 282 have received at least one phone call. And of these 282 patients who have received at least one call, 168 have completed the survey and 67 were unreachable or declined to participate. Of the 168 patients surveyed, 132 provided cardiologist or healthcare provider contact information. And contacting the cardiologist or the healthcare provider they're seeing as an outpatient is really the last step in the sequential process. And of these 132 providers, 26 have completed the survey. The remaining 106 are in the process of being contacted and will continue to collect information. Next slide. And I'm going to move on to an update on the safety of Janssen COVID-19 vaccine. Next slide. So this is a screenshot from a presentation given by Dr. Nair from FDA at the VRBPAC meeting on post-authorization safety data for Janssen. Next slide. This is a schematic of the surveillance process with respect to the vaccine adverse event reporting system. Next slide. This is a listing of the most commonly reported adverse events to VAERS after Janssen COVID-19 vaccination. Systemic and local reactions are the most commonly reported adverse events to VAERS. Next slide. During this presentation, which again, you can access the full presentation at the link below, they reviewed some existing safety concerns and also described some emerging potential safety concerns following Janssen vaccination. CDC and FDA will continue to follow cases of Guillain-Barré syndrome and thrombosis with thrombocytopenia syndrome, or TTS, reported to VAERS. Information regarding these adverse events are currently communicated in the EUA fact sheets. And FDA and CDC continue to assess cases of myocarditis, pericarditis, immune thrombocytopenia, and thromboembolic events reported to VAERS following Janssen COVID-19 vaccination. FDA real-time surveillance has not revealed any safety signals for these adverse events at this time. Next slide. So CDC conducts rapid cycle analysis through the vaccine safety data link. This is near real-time sequential monitoring for pre-specified surveillance outcomes of interest conducted weekly. A relatively small number of Janssen vaccinations have been administered compared to mRNA COVID-19 vaccinations, about 440,000 compared to 14 million total mRNA COVID-19 vaccinations. No statistical signals have been detected for any VSD, Rrca pre-specified surveillance outcomes following Janssen COVID-19 vaccination in the 1 to 21 day risk interval. Descriptive analysis indicates an imbalance of GBS cases following Janssen vaccination compared to mRNA COVID-19 vaccination, with proportionally more GBS cases being observed after Janssen COVID-19 vaccination. Next slide. So this is a screenshot of the CDC health alert that went out in April after CDC and FDA detected cases of cerebral venous sinus thrombosis with thrombocytopenia after receipt of the Janssen COVID-19 vaccination. There was a pause on vaccination while CDC and FDA assessed the signal, and vaccination was resumed shortly thereafter, the assessment. Next slide. Since that time, CDC and FDA have continued to closely monitor TTS cases after Janssen vaccination. And as of October 13th, there were 47 confirmed cases after 15.3 million doses administered. The table here shows the reporting rates by age group and by sex. The basic epidemiology or trends have not changed from earlier presentations that I've given at ACIP. The reporting rates are higher in females compared to males and highest in the female age groups 30 to 39 years and 40 to 49 years. These cases include 5 deaths related to complications from TTS. The median age in these deaths is 37 years. 4 of the 5 were female, and all 5 had cerebral venous sinus thrombosis. None received heparin. The median platelet count nadir was 15,000. Anti-PF4 antibody ELISA testing was performed on 4 of the 5, and all were positive with optical density values greater than 2. Next slide. So to sum up the Janssen safety monitoring, the current evidence suggests a causal association for TTS, though the condition is rare. Most cases are in women and most age 18 to 49 years old. Monitoring in VAERS and VSD suggests a possible association between GBS and the Janssen COVID-19 vaccination. CDC and FDA and federal partners will continue to assess emerging potential safety concerns, which include myocarditis and pericarditis, ITP, and thromboembolic events. Next slide. I'm going to finish up with a brief analysis on the safety of Janssen COVID-19 primary vaccination, followed by an additional mRNA COVID-19 vaccine dose. And this is information from the data from the Vaccine Safety Data Link. Next slide. So I mentioned that VSD conducts Rrca, and as of October 16th, there are approximately 14.3 million doses that have been administered and around 7.2 million members that are fully vaccinated. You see those vaccine combinations and fully vaccinated individuals there on the right-hand column. There were a relatively small number of individuals where we suspect had a Janssen plus an mRNA dose. And of this roughly 5,400, we split out the Janssen plus an mRNA dose, individuals who got a Janssen plus an mRNA dose with a minimum of 60 days between doses. So an interval of 60 days between the Janssen primary and then the subsequent mRNA COVID-19 vaccination dose. And that's 3,662. Next slide. So here's the demographics of those 3,662 individuals with that vaccination combination, slightly more males than females, but that's consistent with Janssen vaccination in general in the VSD. Next slide. This is a table, reference table, just showing the VSD pre-specified surveillance outcomes. Next slide. So among the 3,662 persons who received a Janssen primary vaccination and a subsequent mRNA vaccination at a minimum interval of 60 days after the Janssen primary dose, 2 pre-specified surveillance outcomes were detected in the 1 to 42-day risk interval. An acute myocardial infarction in a male between the ages of 50 to 64. The interval between the Janssen primary and the subsequent mRNA COVID-19 vaccination was 125 days. And then a seizure in a female in the age range 25 to 29 years old, the interval between the Janssen primary and the mRNA vaccination was 142 days. Next slide. So limited data are available on the Janssen primary vaccination, followed by an additional mRNA COVID-19 vaccination at a minimum interval of 60 days after the Janssen primary. And there is a lack of evidence to date of a safety problem with respect to any of the pre-specified VSD surveillance outcomes for this vaccination practice. Next slide. I'm going to take a moment here to remind our partners in the healthcare community, the public health community, and members of the public that you can participate in vaccine safety monitoring. Specifically, report adverse events following vaccination to VAERS, even if you aren't sure if the vaccination caused the adverse event. Enroll yourself in vSafe. Healthcare providers, please encourage your patients to enroll in vSafe. And parents and guardians, you can enroll your children in vSafe, which we think will be important as we start vaccinating younger children in the near future. Please get involved. Your participation matters. Next slide. Next slide. Next slide. Thank you, and that concludes my presentation.
Thank you, Dr. Shimabukuro, and thank you for doing that very broad overview for us to make sure we have as much information as possible in all the vaccine safety systems. I also just want to take a moment to thank all of our colleagues from the different vaccine safety surveillance systems, some of whom are on the line. We're really appreciative of all of the collaboration and coordination that's gone into ensuring that we have a robust picture of vaccine safety in the U.S. I'm going to open this up very briefly for just clarifying questions. And again, remember, you can ask additional questions at the end. Are there any clarifying questions committee members would like to ask? And as a reminder, we're going to discuss myocarditis in further detail for the next two presentations. Okay, I don't see any hands raised, so Dr. Shimabukuro, your presentation was very clear. Thank you. We will move on to Dr. John Su, who will present on VAERS data and specific to myocarditis. So Dr. Su, the floor is yours.
All righty, good afternoon, everybody. Can everyone hear me all right? Thought I'd check.
Yes, we can hear you. Please go ahead.
Okay, thanks. All right, if you just advance to the next slide, please. And next slide, please. Okay. Next slide, one more, please. So as of October 6th, we've had a total of 402,469,000, a bit more than that, doses of the different COVID-19 vaccines administered. During that time period, we had reported to VAERS a total of 3,336 reports of myocarditis or pericarditis. 2,459 of those reports were of myopericarditis and 877 were of pericarditis alone. And I'll just be referring to myocarditis and myopericarditis collectively as myopericarditis. Next slide, please. So on this slide, these present the data current as of October 6th. On the left side, the breakdown is by manufacturer. And then to the right, we have a number of reports after dose 1, dose 2, and then those reports for which dose number was not reported. Although the counts have been updated, we see that the pattern remains similar to past updates, where most reports are after dose 2, and of dose 2, most reports were after Pfizer or BioNTech's vaccine. Next slide, please. Over here, we have some descriptive characteristics on the left, and on the right, counts broken down by dose 1. I just include the mRNA vaccines because there are very few of Janssen's, and then by dose 2 next to that. And we might note for the median age and time to onsets, rather than presenting a range, we're actually presenting the interquartile range, which we felt to be a better indicator of where most of these reports are falling. Again, counts have been updated, but the overall epidemiologic trends remain the same. Generally, after dose 2, we have a younger median age, a slightly earlier median time to symptom onset, and a greater proclivity towards males relative to after dose 1. Next slide, please. So in past updates, we've actually presented an observed versus an estimated expected counts by age groups. And we felt that perhaps a more neutral way of presenting that data would be to present reporting rates by age and sex and manufacturer. And so that's what we see on this slide here. So of the mRNA vaccines, there were a little over 366 million doses of dose 1 or dose 2 of the mRNA vaccines administered. And we see the reporting rates by age group. Age groups listed on the left, and then on the right-hand side, broken out by manufacturer, and then by dose number. Now, this is inclusive of both sexes. And what we see is that in those highlighted cells, those correspond with a reporting rate that exceeds the estimated 1 to 10 per 100,000 person years observed in the background. And that's true after Pfizer's vaccine for ages 12 through 24 years of age. And then for Moderna, ages 18 through 29. In both cases, only after dose 2. Next slide, please. And this slide presents reporting rates after mRNA vaccines among males. Within this group, we had 169,700,000 doses administered. That includes dose 1 and dose 2. And we can see that after Pfizer dose 2, reporting rates among ages 12 through 29 exceed the background rate, and after Moderna for ages 18 through 29 years. Again, only after dose 2. Next slide, please. This slide presents reporting rates observed among females after dose 1 and dose 2 by manufacturer on the right. There were 193,200,000 doses of mRNA vaccines, dose 1 and dose 2 administered during this time period. And we can see that reporting rates for females do not appear to exceed the background incidence. Now, I do asterisk after Moderna dose 2 for age groups 18 through 29, that there might, if you were to take into consideration how long the COVID-19 vaccines have been in use, namely less than a year, and that there is an observed increased incidence of myocarditis among males relative to females, that there potentially could be a slight, these reporting rates could actually be a little bit above the background if you were to take those adjustments into consideration. But that is a possibility and not a firm one. Next slide, please. So just a brief mention about care and outcomes. Next slide, please. So there were 1,640 reports among persons 29 years of age or younger. Of those, 877 met the CDC case definition of myopericarditis or myocarditis. And of those 877, most 829 were hospitalized. Most of those, 789, were discharged, and 3/4 of those discharged were known to have recovered from their symptoms at time of report. So again, counts are updated, but overall we see a pattern consistent with past updates. Next slide, please. So just to briefly sum up, next slide, please. So as of October 6th, we had a total of 3,336 reports of myopericarditis or pericarditis to VAERS. The epidemiology has remained consistent with previous reported updates. We're primarily seeing myocarditis in the younger males after dose 2 of mRNA vaccination. The limited follow-up data that we have do suggest most patients recover from their symptoms, and that reporting rates of myocarditis exceed background rates among males after dose 2 of Pfizer for people ages 12 to 29 years, and dose 2 Moderna for folks aged 18 to 29 years. And I'll just add that all these data are from VAERS, and VAERS does have certain limitations that I'm sure people are aware, which includes things like reporting biases, limitations in terms of data quality, and the like. Slide, please. So just a brief shout out to those folks who helped make these data possible, including our state and local partners. Next slide, please. And that's what I came prepared to present today. So thank you very much, and back to you.
Thank you, Dr. Su. We're just going to open this presentation for clarifying questions only, and I see Dr. Paling has her hand raised. Dr. Paling?
Okay, thank you, Dr. Su, for this presentation. I would like to, I did see that 77% of the people that met the definition and were less than 29 years of age had recovered. Were there any long-term outcomes or deaths that have been detected? Thank you.
We are aware of a couple of deaths reported after myocarditis, but there's no evidence that directly indicates that the myocarditis was the cause of death in these patients. Aside from that, we don't really have a lot of longer-term follow-up. The VAERS data weren't designed to collect those information. That's why we have that longer-term project that Dr. Shimabukuro has mentioned, that those data are pending.
Dr. Lair? Dr. Lair, there you go.
Slide 8. On slide 8, you've got the data for the number per million cases. And it looks like it ranges from like 30 up to maybe 69. On the footnotes, you have that the background rate is 1 to 10 per 100,000. And it appears that 69 per million is 6 per 100,000, which fits in with that background rate. And I just wanted to see if you had a comment on that, because are you just using the 1 per 100,000 as your limit for the background rate? For if it's higher than that, that's when you're going to mark it as possibly significant?
Okay, I have to apologize. I wasn't following the slides here. So which specific cell were you referring to again?
So let's just choose 16 to 17, Pfizer dose 2. You have 69 per million doses, which is 6.9 per 100,000 doses. And in the footnotes with the 2 stars, the background rate is estimated at 1 to 10 per 100,000. So that seems to fit within the background rate. And just wondering about that, how you're using the background rate to decide when you're above the background rate.
Yes, sir. I do understand why that might be a bit confusing. So yeah, it does fall within the 1 to 10 per 100,000. If we go on the lower end of that, then you're correct. Then we would be exceeding background. We have been conducting additional review of the literature, which does suggest that although the estimated background was 1 to 10 per 100,000 based upon the couple of reports that we have seen and referred to, some newer data does suggest that that 1 to 10 may actually be closer to 1, as you just mentioned. So we can hopefully provide some more refined estimates down the road in terms of background. But you're correct. While we are within the 1 to 10 range, if you do look at the lower end of that, we do exceed.
Thank you.
Thank you. Let's move on to the next presentation, which is Dr. Nikki Klein, who will be presenting some updates from the Vaccine Safety Data Link on myocarditis. Dr. Klein, the floor is yours.
Good morning, good afternoon for those of you in the West, for those in the East Coast. Next slide. So I think, as you heard from Dr. Shimabukuro, the Vaccine Safety Data Link was established in 1990. It's a collaborative project between the CDC and 9 integrated healthcare delivery organizations. You can see listed shown on the map here, and includes data on more than 12 million members of VSD healthcare sites. Next slide. So the aims of the rapid cycle analysis, or RCA, as you've been hearing about, were to monitor the safety of the COVID-19 vaccines weekly using pre-specified outcomes of interest among VSD members, and then to also describe the uptake of COVID-19 vaccines over time among eligible VSD members and in groups of age, site, and race ethnicity. And we began surveillance in December 2020. Next slide. So here are all the outcomes being monitored. However, we've shaded the myocarditis pericarditis outcome, as you can see a little bit of the details of the algorithm, how we identify the cases, because I'll be focusing exclusively on this outcome in today's presentation. Next slide. So all the analyses and vaccine uptake that I'll be showing you in the subsequent slides are for data through October 9th. 2021. Next slide. So to date, as you heard from Dr. Shimabukuro in the VSD, we had over 14.2 million doses of COVID-19 vaccines administered, and includes nearly 72% of the VSD population has been fully vaccinated. Next slide. So as you can see here, these are how the vaccines have been distributed and administered to the VSD members. Vast majority are the mRNA vaccines, as you can see with both the Pfizer and the Moderna products in red and blue respectively, and just under 450,000 doses of Janssen have been administered. Next slide. So here is the first dose totals by week of administration, and this is limited just to the 18 to 39-year-old age group, which is most of the focus of the talk that I'll be giving, not exclusively, but most of the focus. So I wanted just to show you that for the Pfizer in red and the Moderna in blue, you can see that the administration over time has not varied that much, and it's very similar between the two vaccine products. And you can see in the table that you have the number of doses and also the number of dose twos, which are not shown in the graph, but the numbers are on the table for the two products. So that, again, this is 18 to 39-year-old age group. Next slide. Just a word about our dose 2 for the days between dose 1 and dose 2 intervals for the mRNA vaccines. Again, this isn't all VSD members who are 18 to 39-year-olds. As you can see in red, that most of our members of this age group received a dose 2 at day 21 as per the recommended intervals, with some scattering days around that from the week or two after. Similarly to for Moderna, you can see also that most people received the second dose of Moderna on day 28, again with small variability in the week or so afterwards. Next slide. So moving on to the analytic strategy for our Rrca monitoring. So for the primary analysis, the number of outcomes observed in the risk interval, which was 1 to 21 days, after COVID-19 vaccination were compared to the number expected. Expected were derived from what we call the vaccinated concurrent comparators, who were in a comparison interval on days 22 to 42 after COVID-19 vaccination. So on each day that an outcome occurred, a vaccinee who was in a risk interval were compared to a similar vaccinee who was on that same day in their comparison interval, and we adjusted all the analysis for age group, sex, race, ethnicity, VSD site, and calendar date. I'll be describing that again pictorially. Next slide, and this next slide, just to make sure it's a little clearer. You can see here in this example of what our analytic strategy is, and it happens to be the representative for myocarditis, but this refers to all the outcomes, which I'm not showing today, but that does the same analytic strategy. But here we have the vaccinees, and this is the vaccinated concurrent comparator analysis. These are showing a vaccinee with, for example, myocarditis in the risk interval and concurrent comparators. In the upper panel, you can see the representative individual who on June 3rd had myocarditis, and that individual was vaccinated on May 30th. And so that person was in their risk interval on the 1 to 21 days post-vaccination. And that person was being compared to another person who on June 3rd was a similar person. And that similar person meant that they're the same age group and at the same sex, race, and at the same VSD site, but happened to be in their comparison interval because on June 3rd, that comparator was vaccinated on May 3rd. So this is the analytic strategy for the Rrca surveillance. Next slide. So here is the most recent surveillance for a sequential analysis in the 21-day risk interval after either dose of any mRNA vaccine, again, compared to the outcome events and vaccinated comparators using the analysis I just showed you on the same calendar day. And what you can see here for myocarditis pericarditis is that our weekly surveillance, including all ages of everyone in the VSD, met our signaling criteria of having a one-sided p-value less than 0.0048. As you can see that p-value, and so we actually have signaled in the VSD for myopericarditis for all ages. And again, these are adjusted analyses for VSD site, age, sex, race, and calendar date. Next slide. Now for here on in, I'll be just focusing on a subgroup of cases of confirmed myocarditis and pericarditis after mRNA vaccines. And again, this data is through October 9th, 2021. Next slide. So we chart review all cases that we identify for individuals 12 to 39 years of age. And these cases are through October 9th. We've chart reviewed 132. There's only out of 135 and 3 are still pending. Again, these are 12 to 39-year-olds. And all cases following initial chart review are adjudicated by either an infectious disease clinician or a cardiologist. Now, this adjudication has confirmed that 103 of the 138, or 78%, are myocarditis pericarditis cases. And of those, 74 are amongst 12 to 39-year-olds during the 0 to 21 days. 44 are amongst 18 to 39-year-olds in the 0 to 21 days. And 39 are amongst 18 to 39 in the 0 to 7 days after dose 1. Now, there are a lot more information and details about the chart confirmation than the chart on the cases from the chart reviews that are in your backup slides, so I will not be talking about them any further right now. Next slide. This slide here shows the days of onset of confirmed myocarditis pericarditis amongst 12 to 39-year-olds after either dose of mRNA vaccine. And what you can see here is that the cases, just visibly, you can see that they cluster within the first week after vaccination. And when we do formal temporal scan statistics, you can see that we found 3 overlapping clusters identified between days 0 to 4, 0 to 3, and 0 to 5. And you can see the p-values that are highly statistically significant. So for most of the next analyses, I will be showing just 0 to 7 day analyses, not most of them. Next slide. So here is the confirmed myocarditis pericarditis 0 to 7 day risk interval among 12 to 39-year-olds by products and dose. Again, this is the vaccinated concurrent comparators with the same analysis I showed you previously. So there's a couple things to note on this slide is that when you look at both mRNA vaccines, that they're very high adjusted rate ratios. You can see after both doses is nearly 22, and they're all highly statistically significant. You can see the lower bound of confidence interval for both doses, both Pfizer and Moderna. And a note here that the Pfizer, as please note, includes ages 12 to 39, while Moderna only includes ages 18 to 39. So these two rate ratios cannot be compared because you have different age groups in these two groups. But what is being shown here is that you compare the risk interval events to the comparison intervals, and that's what is being evaluated in the rate ratios. But what we see here is that the take-home really is that both vaccines in the 0 to 7 day risk interval are associated with an elevated rate ratio of myopericarditis. Next slide. Now, when we look at the confirmed cases in the 0 to 7 day risk interval among 18 to 39-year-olds, we can see again that there's an elevated rate ratio after both mRNA vaccines that's highly statistically significant. You can see that for both Pfizer and Moderna. Again, this is the same age group of 18 to 39, and you can see that for both vaccines that the rate ratio is elevated after both vaccines. Now, this, just numerically looking at the numbers, you can see that after the rate ratio after after Moderna may be higher than the rate after Pfizer. And so this may suggest that there's indirectly suggests that Moderna might have a higher rate than after Pfizer. Next slide. Just a word about the cases among the 12 to 17-year-olds. Again, this is Pfizer only, and this is both the 0 to 7 and 0 to 21 day risk interval. And what you can see here, there's a couple of things that stand out really quite strikingly is the number of events in the risk interval, up to 30 after both doses from 0 to 21 day, and 0 events in the comparison interval. And when we do the analysis, we can see that the rate ratios are very high. We can't estimate it because there's 0 cases in the comparison interval, but they're very high, and you can see the lower bound of confidence interval is what to focus on, is elevated for both dose analysis and dose 2 analysis. Next slide. So really the summary of these three slides I just showed you is that the analysis of the vaccinated concurrent comparators indicate that both Pfizer and Moderna are associated with increased risk of myocarditis, pericarditis in 12 to 39-year-olds. And again, as a reminder, the Pfizer results included 12 to 39-year-olds, while Moderna is only 18 to 39-year-olds. The analysis of the vaccinated concurrent comparators indirectly suggests that Moderna is associated with more risk of myocarditis, pericarditis than Pfizer. However, to directly test whether the risk of myocarditis and pericarditis after Moderna differs from that after Pfizer, we conducted head-to-head comparisons on 18 to 39-year-olds. Next slide. So again, these are having the same cases that are confirmed case myocarditis and pericarditis through October 9th. Next slide. So here, just to emphasize that these are the days between dose 1 and dose 2 for confirmed cases in the 0 to 21 day risk interval, and you can see that we see the same pattern as we saw in the entire VSD population in the same age group, that most individuals receive their second doses per recommended 21 days after Pfizer or 28 days or shortly thereafter for Moderna. Next slide. So here is the incidence of confirmed myocarditis, pericarditis in 18 to 39-year-olds, and this is Moderna versus Pfizer. And this is what you can see here, focusing on the line, which represents the rate per person years. The Pfizer line in red and Moderna in blue, you can see that during the first 7 days after vaccination, that the incidence rate after Moderna is higher than after Pfizer. You can just see that visually. Next slide. So here is the analysis, and this differs from what I've been showing you in terms of head-to-head. It differs from what the vaccinated concurrent comparators I have been showing you, because in this case, Moderna and Pfizer vaccines were directly compared only during the risk interval within groups. Now, these groups are comprised of individuals inside the risk interval, and that's either 0 to 7 or 0 to 21 days after vaccination. Individuals of the same age group, sex, and race ethnicity from the same VSD site and on the calendar day when an mRNA vaccine had myocarditis, pericarditis. The estimated rate ratio was 95% confidence intervals, and that's the rate post-Moderna divided by the rate post-Pfizer, again, only during the risk interval. We tested the null hypothesis that the rate of myocarditis, pericarditis after vaccination does not differ between Moderna and Pfizer. Next slide. And you can see that graphically shown here. For example, a 28-year-old male had myocarditis on June 28th. He had been vaccinated on June 23rd and therefore was in the 0 to 7 day risk interval. And the comparators for this case included everyone who on June 28th was in the 0 to 7 day post-vaccination risk interval after either vaccine, meaning that they were vaccinated on June 21st, between June 21st and June 28th, for example. Next slide. So here are the results of the myocarditis, pericarditis in 18 to 39-year-olds directly comparing Moderna versus Pfizer. Now, what you can see here after both doses of vaccines in the 0 to 7 day risk interval, the adjusted rate ratio comparing Moderna to Pfizer was 2.56. That was statistically significant in the lower bound of confidence intervals and a significant p-value. When you look at 0 to 21, we saw similar results just below that. And then after dose 2, we also see very similar results, both the 0 to 7 and 0 to 21 day risk interval. Next slide. Now, when we look at myocarditis and myopericarditis, and we excluded pericarditis from this analysis, again in the 18 to 39-year-olds, directly comparing Moderna versus Pfizer, we still see, again, that during the 0 to 7 day risk interval after both doses, we see a statistically significant elevated rate ratio of 2.24. That was similar also for dose 2. Now, the dose 0 to 21 day interval was similar, but no longer just missed a statistical significance, but the trend is very similar to what I showed you in the prior slide. Next slide. So to summarize, a number of analyses, including those I'm not showing you all the details of, but here, this is, again, in the 0 to 7 day after, now this is just dose 2, and this is amongst 18 to 39-year-olds, Moderna versus Pfizer. And here you can see, regardless of whether the analysis includes pericarditis or doesn't, or whether it includes both sexes or males, you can see an elevated rate ratio comparing Moderna and Pfizer. Now, one of the things that what this tells us also is that the elevated rate ratio is elevated for both sexes, and it's not more elevated for males, but it's elevated for both sexes. And that Moderna is not associated with more myocarditis than Pfizer in males particularly. And you can see that in for example, when you look at the excess cases for that first row, you can see that there's 13.3 excess cases per million doses when you compare Moderna for Pfizer after dose 2 for both sexes. Next slide. So to summarize the initial analysis showed you of the vaccinated concurrent comparator of the Rrca analysis, the VSD formally signaled for myocarditis pericarditis in the 21 days after both mRNA doses in the overall VSD population, including all ages greater than 12 years. In the subgroup aged 12 to 39 years, the rate ratio for myocarditis pericarditis was elevated after both Pfizer and Moderna during days 0 to 21 after vaccination, especially during days 0 to 7. As a reminder, the Pfizer results included 12 to 39-year-olds, while Moderna only included 18 to 39-year-olds. So in subgroup analysis, both mRNA vaccines were associated with myocarditis pericarditis in persons aged 12 to 39 years. Next slide. Now, to summarize the head-to-head comparison of Moderna versus Pfizer, among 18 to 39-year-olds, the rates of myocarditis pericarditis after Moderna were significantly higher than after Pfizer during both the 0 to 21 and 0 to 7-day risk intervals. The results were consistent when analyses excluded pericarditis. Comparing Moderna versus Pfizer during the 0 to 7 days after dose 2, we estimated 13.3 excess cases of myocarditis pericarditis per million doses. Among 18 to 39-year-olds, there is no clear clinical differences amongst myocarditis pericarditis cases between Moderna and Pfizer recipients. Again, these are in your backup slides, but most had hospital lengths of stay in the 0 to 1 day, and none were admitted to the ICU. And really, the take-home for all of these analyses, putting it together, is that both mRNA vaccines were associated with increased risk of myocarditis pericarditis for ages 18 to 39 years, as was Pfizer for ages 12 to 17 years. Head-to-head comparisons provide evidence that the risk of myocarditis pericarditis was higher after Moderna than after Pfizer. Next slide. I'd like to acknowledge, particularly from our team at Kaiser Permanente, Northern California, Ned Lewis, Kristen Goddard, and Bruce Bryman for all this hard work on these myocarditis analyses, as well as all our adjudicators and the CDC, the Immunization Safety Office, and all the VSD sites who worked very, very hard. Thank you.
Thank you, Dr. Klein. This presentation is open for clarifying questions. And actually, I wanted to ask one specific question. If you could move to slide 16, 17, 18, it's those 3 slides. And actually, it's probably 17 and 18 I wanted to take a look at. So this is 17. I just wanted to confirm. So I'm looking at the excess cases and the risk period per million doses. It's approximately 8.5 for dose 2 following Pfizer series. And then if you go to the next slide, it's approximately 54 per million for dose 2 in this younger age group following the Pfizer series. So I guess I wanted to just confirm, when you're calculating the excess risk in this instance, does it assume a lower baseline rate of myocarditis in the younger age group? Because when you look at I just want to make sure I understand the numbers well enough.
Right. So for these slides, when we calculated the excess cases per million doses, we divided the risk interval Crude incidence rate by the adjusted rate ratio, and then it subtracted the result from the risk interval's Crude incidence rate.
Just because it looks a little bit different from the VAERS data in terms of there being more of a U-shaped curve in the younger 12 to 16 being a little bit lower and a little bit higher in the 17 to 18. recognizing these are different systems and different calculations, but I'm just trying to wrap my brain around it. But we can maybe sit on that and see if there's any additional clarifying questions.
Right. If I could.
Oh yeah, sure.
If I could show, again, as you just pointed out, Dr. Lee, that we can't really compare the two systems, and that there are actually quite a few differences. But we do have. If you could go on the backup slide to. Sorry, I think it's slide 51. So this here is our incidence rates that are in the Crude, and this is not per age, broken up by age, but these are our Crude incidence rates per person year in our in the VSD in our data in the 18 to 39-year-olds. And I don't know if this is helpful, but you can see these are the incidence rates that we have for the risk interval, and then also the incidence rates for our comparison interval per 100,000 person years, 0 to 7 days after vaccination.
Thank you. I don't see any additional hands raised for clarifying questions. So if all of our speakers will stay on the line, but we'll move on to the VAST assessment by Dr. Kip Talbot, who is the co-chair with Dr. Bob Hopkins of the VAST work group. So Dr. Talbot?
Yes, and I appreciate everyone sticking through all of that data. It was a lot of data, and hopefully I'll be able to summarize it, hit the highlights, and then do an assessment that the VAST committee created. So I also want to thank Dr. Hopkins for doing this with me. Next slide. So the topics today, we'll do a brief review of the VAST objectives and activities. We'll do a brief overview of selected Moderna and Janssen COVID-19 vaccination safety data. And then we'll have VAST assessments for the Moderna COVID-19 vaccination, and this will include original series and booster. Similarly, same for Janssen's COVID-19 vaccination, and we'll touch on heterologous boosting, and we'll discuss future VAST plans. Next slide. So the COVID-19 Vaccine Safety Technical Work Group, better known as VAST, and the objectives were and will be to review, evaluate, and interpret post-authorization approval COVID-19 vaccination safety data. It is serving as a central hub for technical subject matter expertise from federal agencies conducting post-authorization and approval safety monitoring. Advise on analyses, interpretation, and data presentation, and provide updates to the ACIP COVID-19 Vaccines Work Group and the ACIP on COVID-19 vaccine safety. Next slide. VAST continues to review COVID-19 vaccination safety data for both passive and active surveillance systems. This includes in the U.S. and outside of the U.S. U.S. safety monitoring systems include the Vaccine Adverse Events Reporting System, otherwise known as VAERS, Vaccine Safety Data Link, FDA BEST System, VA, Indian Health Service, and Department of Defense. We have also listened to data from outside, including Israel, Canada, and the Global Advisory Committee on Vaccine Safety. And there are special evaluations underway, such as the follow-up studies of myocarditis cases. Next slide. So this is a slide that has been updated and now includes 2 slides, but in brief, since December 21st, 2020, we've had 38 independent meetings to review vaccine safety and 10 joint meetings with the COVID-19 Vaccines Work Group focused on safety. And as you can see on this slide and the next, you can move. You can see the dates and topics that were discussed. Next slide. So briefly, we'll talk about myocarditis and pericarditis of the Moderna COVID-19 vaccination. So myocarditis follows messenger RNA COVID-19 vaccination, and this was first identified in May of 2021. The CDC issued clinical guidance for myopericarditis following vaccination, and the data was presented at the VRPAC meeting in June. Data and VAST assessment were presented to ACIP later in the month of June, and an MMWR was published. EUA fact sheets revised with warning added in June 25th. Even when Pfizer-BioNTech received its final FDA approval, information on myocarditis, pericarditis was included in the package insert. Next slide. Data available to date show association of myocarditis with both messenger RNA vaccines in adolescents and young adults, males greater than females. Some systems show greater risk after Moderna than Pfizer. This includes the United States VSD and Department of Defense, Canada data, and Scandinavian countries. Other U.S. safety monitoring systems do not show a difference between the two messenger RNA vaccines. Hence, further data is being compiled to understand the differences between the safety systems, optimal management strategies, and long-term outcomes. Next slide. When it comes to dose 3, there is data from the clinical trial. Please note that the clinical trial data is based on the 50 microgram dose in 171 participants. There was no evidence of increased reactogenicity following a booster dose relative to dose 2, with the exception of increased axillary swelling tenderness of the vaccination arm. There is post-authorization safety data for a dose 3. I'd like to highlight this is most likely the 100 microgram dose, as the 50 microgram dose has not previously been available. This data comes from VSafe and VAERS. Only people who are immunocompromised are currently recommended to receive a third dose in Moderna, but it is unclear if these were just patients who were immunocompromised or not. VSafe had 14,000 persons who reported dose 3. Local reactions were reported slightly more frequently and systemic reactions slightly less frequently following dose 3 than dose 2. VAERS had approximately 1,400 reports after a third dose. Over 92% of reports were non-serious. Next slide. We're going to discuss the safety of Janssen, specifically TTS and GBS. TTS surveillance continues in VAERS. Identified reports of CVST and TTS. Use of the vaccine was paused temporarily on April 13th. EUA fact sheets were updated with warnings about TTS, and pause was lifted on April 23rd. Through October 13th, there have been 47 cases of TTS. Most cases are in women aged 18 to 49 years of age, and the evaluation is ongoing. We have not seen increasing rates, but a steady rate. Guillain-Barré syndrome, surveillance in VAERS identified reports of GBS, higher than expected reporting, especially in males greater than females, and EUA fact sheets updated with information about observed risk July 12th. Through July 24th, 130 cases of GBS have been identified, and observed reports are higher than expected across multiple age groups. Next slide. Janssen COVID-19 vaccination safety data on dose 2. There is clinical trial data. Approximately 9,000 participants received 2 doses at least 2 months apart. Approximately 2,700 have had at least 2 months of safety follow-up. There have been no new safety signals identified following a second dose. The interpretation is limited by small sample size and short interval. There is post-authorization safety data. Please note that this is data from people who've decided to get a second dose without recommendation. Be safe, there have been 83, and in VAERS, there were 39 reports. All the reports were non-serious in VAERS. Next slide. So the VAST assessment for the primary series. For Moderna, there appears to be a slightly increased risk of myocarditis among 18 to 39-year-olds after Moderna compared with Pfizer vaccination, especially in males. Preliminary data from follow-up study based on data from patients and parents suggest the cases are generally mild, but study is ongoing. Janssen COVID-19 vaccination, risk for TTS and Guillain-Barré syndrome appear to be unchanged from earlier assessments, serious but rare. So we believe it's important to continue to communicate to the public and patients the balance of benefits and risks. Next slide. Fast assessment summary on booster doses. Moderna COVID-19 vaccination. There's limited data on risk of myocarditis after a third dose. Please remember that what we have in post approval has been 100 microgram dose. Data on safety of the reduced 50 microgram dose only available from a small clinical trial. And it's unclear if the risk of myocarditis will be the same or reduced with the reduced dose of the Moderna booster. Janssen COVID-19 vaccination. There's limited trial data and data from safety monitoring systems for dose 2. Risk after booster dose are unlikely to be greater than with primary vaccination, which, as a reminder, is TTS and Guillain-Barré syndrome. It's important to communicate to public and patients the balance of benefits and risks. Next slide. Fast assessment of the heterologous booster. Preliminary data from the NIH Mix and Match study and limited data from post-authorization safety suggest that boosting of Janssen COVID-19 vaccine recipients with a messenger RNA or of a messenger RNA COVID-19 vaccine recipients with Janssen COVID-19 vaccine poses no additional safety risk compared with homologous boosting. There is no evidence to date of safety concerns with respect to any of the pre-specified VSD surveillance outcomes for Janssen COVID-19 vaccine recipients who received an additional dose of a messenger RNA COVID-19 vaccine. Next slide. The VAS will continue to review safety regarding additional and booster doses as data becomes available. We will continue to collaborate with global vaccine safety colleagues on key issues that impact benefit-risk balance. And we will provide updates to the ACIP COVID-19 vaccines work group and the ACIP at future meetings. Next slide. You can tell this is it's a village to make this work. I really want to especially thank Robert Hopkins, my co-chair, and our CDC co-leads, Lori Markowitz and Melinda Wharton, who have really steered the ship. We have a vast number of members and ex officio and liaison representatives. We greatly appreciate their input and support and data sharing. Next slide. Okay, done.
Thank you, Dr. Talbot. I will now open all of the presentations from this session for questions, comments, clarifications. Dr. Long.
Yes, thank you very much, Dr. Talbot. I wonder why you conclude that, if there are data upon which you conclude that it is unlikely that Janssen dose number 2 would be as associated with the thrombocytopenia and vascular thrombosis or with Guillain-Barré.
Let me go back to that slide, to the assessment slide for the boosters. I think it's slide 4. Next slide. 13. Yes, okay. So the risks that are referred to here are not the risk of TTS in Guillain-Barré syndrome, since there is not enough dose 2 given to evaluate such rare and serious adverse effects. These risks would be considered those of fever, myalgias, missed work.
Thank you. I misunderstood you to say something different. Thank you.
Dr. Sanchez?
Thank you. No, certainly a lot of information and important information as we decide on as we continue to grapple with vaccination. I have a question from earlier. I believe it was Dr. House's presentation on some comment about zoster and co-administration of the zoster vaccine with the COVID vaccine, and that there was, I think it was just a comment. Have you seen any that it was like reactive, like an occurrence of zoster? Just looked up because certainly these individuals are in that range, and I've been asked a lot about co-administration of zoster vaccine with with COVID.
Dr. Shimabukuro, are you online and would you be able to take that question?
Yes. So I believe that what we're looking at there is co-administration of COVID-19 vaccines with other vaccines, and that observation was specific to when COVID vaccines are administered with Zoster vaccine. And one of the things we know from monitoring Zoster vaccine is that herpes zoster is a common adverse event that's reported after Zoster vaccine. And there's probably many reasons for that. One thing is it's something that you possibly a provider wouldn't expect, although it's not totally unexpected. Therefore, it gets noticed and reported to VAERS. So we've just observed from monitoring Zoster vaccine itself that that's commonly reported. And we don't have any evidence that the administering the two vaccines increases the risk for that, or that there's some type of disproportionality there. I think what you're seeing is the fact that is really that is really a result of the co-administered Zoster vaccine and is not related to a COVID-19 vaccination.
Thank you. Actually, I have another comment. And we have recommended, CDC has recommended co-administration of vaccines, and just wanted to bring up that, and this will be discussed at future meetings with the ACAM 2000 and the smallpox vaccines with the, at least with the ACAM 2000 with the pericarditis, and whether that needs to be looked at more specifically in the small population of individuals who are receiving the smallpox vaccine. Just a comment. And then finally, I had another question, if I may. It's really interesting, the Moderna versus the Pfizer associated risks with myocarditis. And it almost suggests that maybe as we try to understand the etiology of the pathogenesis of this occurrence, if it might be obviously related to some direct effect of the spike protein and the cardiac muscle. So it's just really interesting how with the larger dose of Moderna, that's a larger dose, the 100 micrograms, whether there may be a relationship there in terms of the pathogenesis, and hopefully with the booster dose being lower, that it could be, we might see less cases. But just a comment. Thank you.
Thank you, Dr. Sanchez. Any other questions from ACIP members, liaisons, others? While we're waiting for some hands to be raised, I do have one question for Dr. Shimabukuro and team. And I recognize this question is, can you change the wings on the plane as you're flying the plane? But I'm going to ask it anyway, which is, would it be worth considering incorporating chest pain as a solicited AE, not only for clinical trials, so that goes back to the manufacturers, but also wondering if we should consider incorporating that, particularly as we're thinking about expanding to the pediatric population.
And can you specify, like, in what context?
I think in VSafe is the mode that I think would perhaps give us the most post-market safety surveillance data on this particular issue.
I'm reluctant to add. I think chest pain is somewhat of a non-specific adverse event as opposed to myocarditis, which is very specific. And I'm not sure that VSafe is really well structured to capture these kinds of or to monitor for a specific adverse event. It almost seems like it'd be a proxy. And I think we have good systems in place, specifically VSD and also VAERS, to capture these more clinically serious adverse events. So I think that's something we can discuss, but I'm reluctant to add chest pain to VSafe at this point, mainly because I think we have other systems to monitor that, and in fact, encounters with the healthcare system that are captured in VSafe should lead to reports to VAERS. So hopefully we have another mechanism of capturing that indirectly from VSafe, but it's something that we can discuss internally.
Thank you. Dr. Sanchez, did you have another question?
Yes, actually. Thanks, great. No, I just want, it's a comment, and from the presentation so far, I can see the need for a second dose of the Janssen product. However, I just really wanted to say that I remain very, very, very concerned about an administration of a second dose of Janssen, given the risk for, even though it's rare, but the severity of the TTS and then also the Guillain-Barré. I just want to voice that because I think that those individuals who received one dose of the Janssen product do deserve a second of some vaccine, and I was very happy to hear about the heterologous vaccination and the success of that trial. But I remain very concerned about a second dose given the small, rare risk, but very significant risk of TTS, and then of course the Guillain-Barré.
Thank you, Dr. Sanchez. Dr. Talbot.
I just wanted to take a moment to agree with Dr. Sanchez because this has been weighing on me rather heavily. And on the flip, so I worry about young women with TTS with the Janssen, and I flip it over and I worry about myocarditis in the young men. And we really don't know the total outcome of that yet. So I agree. I think the opportunity for these heterologous boosts are priceless. It gives those who receive the Janssen, if you're a young woman, to receive a messenger RNA. And if you're a young man who's received a messenger RNA, maybe we switch over to the Janssen. So we're at a different place in the pandemic than we were earlier. Vaccines readily available. So I think we can take the time to be much more thoughtful and careful when we weigh the benefits and risks. Thank you.
Thank you. And actually, one more clarifying question, and sorry, back to Dr. Shimabukuro or Dr. Su. Do you have any estimates by gender and age for GBS in particular following the Janssen vaccine? I can't recall them. I know you've presented them in the past, and I don't remember if I saw it in the slide deck today.
This is Tom. I don't have any specific data right now, but I will say, and hopefully our FDA colleagues are available to chime in, that the age distribution of the Janssen cases in the VAERS reports has been, the age distribution has been younger than for the mRNA vaccination reports, and in VSD, and perhaps Dr. Klein can confirm, there's also been a different age distribution observed in our VSD monitoring, where the Janssen vaccinated cases somewhat lower than the mRNA vaccinated cases, and it's unclear if that is the result of the way the program rolled out or something else, but I think it is something we've observed in our surveillance.
I don't know if any colleagues from FDA are able to comment, or it sounds like our colleagues in the room also have some slides they can pull up later. So, but just wanted to give a moment for FDA to comment if they have the data handily available.
This is Narayan. I don't know if people can hear me from FDA.
Yes, thank you, Dr. Nair.
Yeah, sure. We recently published an article. Lead author was one of our reviewers discussing the cases of GBS that occurred following the Janssen vaccine, and that appeared in JAMA, and we can circulate the link for that article. It was a case series of 130 GBS cases. The median age was 56 years. It was roughly 60% men and 40% women. Essentially 86% of those cases were in the age range of 18 to 64, and 14% were older than 64 years of age, or 65 years of age, rather. So does that answer your question?
Yes, I think so. And I'm assuming because it was fairly rare and there were only 130 cases that it becomes difficult to really parse out, below the age of 40, for example.
Yeah, that's correct. And that was, I should say that data lock period was from earlier in the summer. So subsequent to that, there are additional cases that we're evaluating. This was as of July 24th, 2021.
Thank you so much.
And I could just comment from the VSD in terms of the GBS, the ages of the cases, Dr. Janssen, is that the mean age was 48, and that there were no cases amongst individuals greater than 65 years.
Thank you so much, Dr. Klein. I do not see any additional hands raised in the moment. I just want to confirm this is last call for hands.
Dr. Lee, this is Dr. Shimabukuro. Can I just make one quick comment?
Of course, thank you.
I just want to mention that we noticed a slight error on the VAERS presentation, and we have, while this session was going on, made that correction, and we'll submit that, and that'll be the one that gets posted for the record, and we can work with you to get that information out to the members.
Thank you, Dr. Shimabukuro. We always appreciate that transparency. Dr. Long.
Yes, it's just a couple of comments about what we have to be sure we still don't know. One would be we don't know the relative use of the Janssen vaccine in individuals over 65. I suspect it's much less than it was in younger people, so the percentage of the cases that are occurring in those age groups aren't as meaningful as it is cases per individuals immunized. The second thing is, I think Dr. Klein summarized that both Pfizer and Janssen, Pfizer and Moderna vaccines cause myopericarditis between, especially in people 12 years of age to 39. And we just can't say anything about Moderna because we don't have individuals 12 through 17 who've received Moderna. And I think it's not terribly clear to me whether the youngest in the group that got Pfizer are more or less likely to have pericarditis. And then the final thing, I do know that we like to talk about excess cases, but to consider a case of traditional myocarditis as the baseline for myopericarditis following vaccine, mRNA vaccines, it just doesn't hold water. It's just not clinically relevant. These are not the same patients. It's apples and oranges. So I know there is no question that there is an association, but we wouldn't want to get hung up on trying to tell the public the number of excess cases because they're not the same disease. That's all. Thanks.
Thank you, Dr. Long. And just as a reminder, even though I recognize we are presenting the totality of the safety data today, that we are focused in on the 18 and older just for the votes later today. Ms. McNally.
Thank you. Can we go back to slide 8, please? Just to avoid any confusion, can someone explain why the systems of VSD, DOD, Canada, and Scandinavian countries are showing a greater risk where VAERS, FDA BEST systems, and the VA are not? And then I have a second question, Dr. Lee, after that.
Thank you. Dr. Shimabukuro, I think you might be the best person to answer this one.
I can speak for VAERS, and then I'll let FDA and the VA folks talk about their system. So VAERS is a spontaneous reporting system. It's not a population-based large link database, EHR claims database system. So, VAERS is subject to the limitations of passive reporting, in that we get what we receive in reports. That said, I think when we look at the VAERS data and we look at the reporting rates by age and by sex, by product type, I think our interpretation is we don't see any obvious signs of a differential risk. We do see some trends, but we don't see any obvious signs of a differential risk. Plus, we really are not able to do the type of head-to-head formal statistical comparison as was done in VSD. So we're a little bit limited in how we can interpret the VAERS data. And then I believe Dr. Nair and maybe Dr. Cunningham are on that can address FDA and the VA systems.
Thank you. Why don't we go to Dr. Cunningham next?
Yes, thank you. In regards to the Department of Veteran Affairs, I think it is due to our age of our patient population. With our results, we did see cases of myocarditis and myopericarditis. We do not signal, however. And if you look at the age of the majority of our patients that have received the vaccine in the earlier slides, it is over 65 years of age. And the myocarditis and myopericarditis occurs in the younger patient population. So I think that may be a reason that we are not signaling. Although when you look at our results, our trends do follow that of the other systems, in that we have more male patients, as well as the myocarditis and the myopericarditis occur in a short period of time after the vaccination and after dose 2.
Thank you. And I see Dr. Forshee, you raised your hand. Would you like to represent FDA?
Yes, thanks. This is Rich Forshee from FDA CBER. Just with regard to, in particular, the active surveillance systems and the slightly different results that we're seeing, I think there's a couple of things to keep in mind when interpreting these results. The first is that these are still rare outcomes, and so certainly in our analysis, we have large confidence intervals, even around the meta-analysis that we conducted of the 4 data partners that we used. There are also, of course, some differences in the patient pools and the different sets, for example, based on geography. And the last thing that I would mention is that in our analysis in BEST, we limited ours to people who are 18 to 25 years, which is a more narrow age range than some of the others that have been reported. So I think those are some of the possible reasons why those are different. And my colleague, Dr. Wong, just reminded me to say that specifically we looked at males 18 to 25 in our analysis. So again, I think those might be some of the possible differences across the systems. Over.
Thank you, Dr. Forshee. We will move on to Dr. Freihofer for the, I think, last question of the session.
Dr. Lee, I'm sorry. I had one more question after Dr. Freihofer.
Actually, why don't you go ahead? Sorry, Dr. Freihofer, just one second. Ms. McNally, please go ahead.
Can you remind us of the risk of myocarditis associated with COVID-19 disease? I think that will be important.
I don't have the paper offhand, and I don't know if any of our colleagues, I'm looking in the room, or actually to our ISO colleagues, but there was that excellent paper that was published out of Israel that compared the risks following COVID-19 infection to vaccination and demonstrated a much higher risk following COVID-19 infection. But I'm going to point at Dr. Oliver in the room and ask if she can respond.
Thanks, Ms. McNally. There is a paper. I agree. I don't have it pulled up right in front of me, but we're happy to make sure that people can have access to that for those exact numbers. But correct, it was comparing that there was a substantial rate of myocarditis that was associated with COVID infection as well.
Thank you. We'll see if we can pull it up. And Dr. Freihofer, please go ahead.
Sandra Freihofer, American Medical Association. Just a clarifying question. Dr. Shimabukuro said that there was a mistake in the VAERS presentation. Which slide was that on?
It was on the tables, and we're in the process of updating those, and we'll repost that presentation.
Can't tell us which slide, so we'll know what.
I'd have to pull up the It was.
We'll get back to you shortly after. I think what we'll do is let's take a 10-minute break and reconvene at 45 after the hour, and any residual questions, we'll try and get those details hammered out and make sure that people have the information they need. Thank you.